Good evening, everybody, and a warm welcome to NRAS's live event for October. And tonight I'm joined by three very eminent professors who are here to discuss everything relating to eyes, eye health and eye complications in rheumatoid arthritis and juvenile idiopathic arthritis. So let me straight away ask our guests this evening to introduce themselves. So Chris, you're first on my screen.
Hi, good evening, everybody. Thanks very much for including me in this event. So Chris Edwards, I'm a rheumatologist in Southampton on the South Coast.
Thank you. Ram.
Thank you, Ailsa. I'm Ram. I'm a pediatric rheumatologist with a special interest in uveitis from Bristol Children's Hospital.
Thank you. And Carlos.
I'm a consultant ophthalmologist at Moorfields Eye Hospital in London, and I have a special interest in uveitis and matters related to ocular inflammation. And that's what we're going to be discussing tonight.
Great, thank you very much indeed. So we've got a lot to cover this evening, and I want to have enough time to get through the questions that you've all submitted very kindly in advance of tonight. So Chris, I'm going to come first to you as a consultant rheumatologist. It was a rheumatologist, I think, that I first saw when I was diagnosed with uveitis. And I think probably most people would go to their GP or their rheumatology team if they had an eye problem. So would you like to give us the rheumatologist's perspective? Over to
you. I will. So I will present my slides. Let's see if the technology will work. So I'm sure it will. Okay, that all looks promising. And I think you will let me know if you can't see anything. Okay, so thank you very much for that introduction, and thanks for the invitation to speak once again. And I was going to give a bit of a rheumatologist view of the eye in rheumatoid arthritis. We might think a little bit more broadly than that as well, to think about how eye disease can help rheumatologists diagnose different arthritis diseases, different rheumatological conditions. And then, as we like to do in hospitals increasingly, we've got a multidisciplinary team tonight as well. So we can check the things that I'm saying with our ophthalmology colleague Carlos and with Ram as well from the pediatric point of view. Okay, a few disclosures to say I've done some work with pharma industry and continue to do some of that, but I don't think it particularly relates to what we're talking about tonight. Okay, so let's start off with just thinking about what the eye is and its importance, of course, with our vision. And I thought I'd spend a little bit of time, and maybe Carlos is going to do this on more detail and will correct me if I get any of the anatomy wrong. But let's just think about what we're talking about when we're looking at an eye. So if you imagine on the left-hand side where it says anterior chamber and cornea, that's the front of the eye. The little bit that's bulging out to the left is the bit that you can see between your eyelids. And all of the bigger part of the eye is within the socket, within the orbit, and buried, and you can't see it. And there's an optic nerve at the back going out, which connects to the brain. And if I go from left to right, there's a cornea at the front, very important structure. Then there's a bit of fluid behind in the anterior chamber. Then the iris, which is the coloured bit of your eye, the blue eyes that we might have, or the green eyes, or the brown eyes. Then the lens, which allows us to focus vision. There's more fluid behind. And then we get towards the back of the eye. And then there are layers around the eye. The sclera is the white of the eye. The retina is the bit that we see in. So there are various different bits that probably help us to think about if we're thinking about how disease like rheumatoid arthritis might affect the eye. And then I've got some terms on the left-hand side, which I think we'll probably talk about in a little bit more detail. So some people with rheumatoid arthritis can have dry eyes. Often that's called Sjögren's syndrome. And when they have dry eyes, the technical term is keratoconjunctivitis sicca. So that just means dry eyes. And then keratitis, you can see all the other words I've got there. I've got itis at the end. So they're all types of inflammation, and they have varying degrees of seriousness. And some of those could be threatening to vision. Keratitis would be inflammation at the front of the eye and the cornea. Then uveitis within the eye. I'm sure we'll get more detail of that later. Scleritis, the white, the lining of the outer part of the eye being inflamed. And then sometimes there's vasculitis in some diseases in the blood vessels at the back of the eye. And for a rheumatologist, the eye is a way of looking into the person. We can see blood vessels at the back of the eye, but it also different things happen to the eye in different illnesses. So we're talking about rheumatoid arthritis now. But in Sjögren's syndrome, which can come with rheumatoid arthritis, dryness is a particular feature and can be a real problem for people. GCA on the bottom left is giant cell arteritis, not related to rheumatoid at all, but something that can cause headaches, can occasionally cause visual loss and pain within the jaw. And then on the other side, sometimes we can get features with lupus in the eye, within ankylosing spondylitis or spondylarthritis, as we like to call those illnesses now. You can get uveitis and then vasculitis. So different diseases can present in different ways in different parts of the eye. So how many people with rheumatoid arthritis might have problems with the eye? Well, it's estimated to be about 20%. Be interested to hear what my colleagues think, but if you look at the literature, that's what it says. And how might you experience that? I think some of these things we get almost as part of normal life, or if we have a virus, or we might get some dryness or grittiness. But persistent dryness, grittiness, irritation, redness of the eye, it can be painful. That's also always a bit more worrying if there's pain inside the eye. There can be light sensitivity or photosensitivity. They may water, and there may be blurred vision. And of course, any threat to vision is important and makes us nervous. So if we look at the front of the eye in someone who has rheumatoid arthritis, we might see different things. So dryness might lead to the eyes looking a bit red. That's the top left. And then in the top middle, you can see scleritis. That would be inflammation of the white of the eye. So the white of the eye might look inflamed, might be painful. Keratitis, and you can see there's a little shadow going across the eye saying that it could affect vision if there was inflammation of the cornea. Uveitis, you might be able to see that the pupil's a little bit distorted because the iris can be damaged by that inflammatory process. Glaucoma, which is a pressure problem in the eye, and then cataracts, where you get clouding of the lens of the eye. We all know about people having cataract operations, but inflammatory disease can sometimes make that worse, and so can some of our drugs, like high doses of steroids can do that. So when do I need the help of people like my colleague Carlos, who's on this webinar tonight? We might need ophthalmologists if we're thinking about hydroxychloroquine toxicity. To be honest, that screening is often done in high street opticians with something called an OCT test, and they're often in areas there are screening services set up in the community. There certainly is in Southampton, in the area I work in. If someone's dry eyes are really resistant, if they've got cataracts or glaucoma, and inflammatory disease, I'm really going to want an ophthalmologist to help me to define where the inflammation is, how bad it is, and we'll think together about how to treat. And sometimes we need super specialist services, the sort of which they have at big specialist eye hospitals like at Moorfields. And rheumatologists and ophthalmologists hopefully work as a team in regard to looking after rheumatoid arthritis eye disease, helping with the diagnosis. We might know more about some of the blood tests and the antibodies and some of the immunosuppressive treatments. The ophthalmologist will know more about examining the eye, about specific ophthalmological conditions, and about the state, the degree of inflammation at the back of the eye as well. So we bring different things. A couple of other comments about treatments. First is to say this doesn't happen to most people, but some people who take steroids, particularly the higher doses that we used more in the past, probably can get problems with glaucoma. So that's a pressure problem within the eye, or are more likely to get cataracts. Many of us will get cataracts as we age normally, but it can be more and quicker if someone's on high dose steroids. And then very, very rarely, and maybe we'll talk about this, people taking hydroxychloroquine, a drug that's used sometimes for rheumatoid arthritis. If you use a lot of it for a long time, it can cause some damage to the back of the eye, and the pictures over on the right-hand side at the bottom show that. So we're cautious about that. We start the drug at a certain dose to reduce problems, and then we screen people and check their eyes if they're going to be on it for a longer period of time. Key things about treatment for me, probably the most important thing to reduce the likelihood of eye disease in rheumatoid arthritis is to treat the rheumatoid well. Like with so many things, if we can treat the inflammation, biological therapy like an anti-TNF, and sometimes we need to use, if people have very dangerous inflammatory eye disease that might damage sight, we might use more aggressive treatments as well as the biological therapies. Just occasionally there might be a need to use what seems an old-fashioned drug now, but something called cyclophosphamide might occasionally be used. So that's the summary of what I was going to talk about. So for a rheumatologist, being able to see the eyes helps us, if there's a problem there, to make a diagnosis sometimes. If someone has the complaints that I've mentioned, the grittiness, the difficulty with vision, that might be part of the rheumatoid arthritis itself. Most of these problems can be treated or even prevented often if we treat rheumatoid arthritis well. And in fact, we see much less of the more serious complications since we've treated rheumatoid with more effective drugs and earlier in the disease course. If you have problems, you can tell a rheumatologist. People will often tell me, speak to the GP, and then we can ask the help of an ophthalmologist. And some hospitals will have 24 hours a day eye hospitals as well. There's where I work in Southampton, there's a 24-hour eye casualty, as they would be at Moorfields as well. And of course, this goes without saying, ophthalmologists can be vital. I will change that and I will say are vital. So thank you very much. And I will stop sharing now. So that's the end of me talking.
Thank you very much, Chris. That was very, very clear. Thank you. Carlos, I'm going to come to you next. And spoiler alert, folks, there are some serious pictures that Carlos is going to include in his summary. So it's very apt that we are the eve before Halloween. Some of these eye pictures might be a little bit spooky, but bear with. So Carlos, over to you.
Thank you, Elsa. Thanks for the invitation. Let me just try sharing my screen here. And I need to just find my presentation here. And give me 1 second, and I should find it. Sorry, I'm just having a slight problem finding my talk. Give me 1 second. That's weird. Okay. It was here, and it's not anymore. Maybe we can.
Jeff, can you come?
Yeah, Jeff, you can. For some reason, it doesn't seem to be appearing here.
There we go.
Okay, here we go. So apologies for that. Thank you, Jeff. Thank you. We will move them slowly here. So you've had a very nice introduction by Chris, and thank you, Chris, for that. It's really well. You laid out very nicely the basics of anatomy of the eye, so you understand better what the parts of the eye are. And I don't have any disclosures regarding this presentation here. Can you move to the next one, please, Jeff? So you know very well the condition rheumatoid arthritis being a chronic inflammatory disease. Usually we think of rheumatoid arthritis as a joint-related disease, but and we know that it's not a very common problem, but the numbers are not that small. You look at the number of people affected globally, and it really makes it up for a good number. And it does produce severe physical disability. Next slide, please. The point is that manifestations of this disease outside the joints, involving other parts of the body, will exist. And I want to show you that it's not that uncommon. So it's not only a joint problem, it can affect other parts of your body. And the eye may be one of them, as already mentioned to you by Chris. And it can be part of disease already established and severe disease, long-term disease, but it can also be a very initial feature that will lead to diagnosis of rheumatoid disease. So it's either way. It could be a presence already in someone who knows and someone who doesn't know yet what they have. Next slide, please. So this is just a very simple slide borrowed from the Cleveland Clinic, showing you here the different parts of the body that can be affected by rheumatoid. And the eye pointing there, it already had some good information about that from Chris. And I'll go a bit more, showing some examples of what happens in the eye. Next slide, please. So the prevalence is about 18% of the patients. So it's more or less what already Chris had told you. It is a common extra joint manifestation of the disease. You already heard about the different possible ways in which it can affect the eye. The symptoms I put in there, Chris already showed them to you as well. So it varies from which part of the eye is affected. And one of the most common things that you see is exactly this keratoconjunctivitis sicca, which is you heard about before. And then, of course, there'll be the other two most frequently seen, episcleritis and scleritis. One important point to mention to you, uveitis is not typically a feature of rheumatoid arthritis. When I find uveitis in the patient with rheumatoid arthritis, it's usually secondary to inflammation of the coat of the eye, with the white part of the eye, the sclera, which is severe enough to produce inflammation inside the eye. Next slide, please. So here's just a little bit of explanation about the dry eye. So it depends on the severity of the dry eye. Your symptoms may vary from just a bit of discomfort to, interestingly, tearing. So patients can get excessive water in the eye. It's a reflex to the lack of proper covers protection of the surface of the eye. On your left, what you see is a cornea, and the color green you see there is that fluorescein dye that we put in your eye. And when the surface of the eye is not well protected, it takes up that green dye, and it shows to us that there is suffering of the surface of the eye, and that's what we can see when we put a drop in your eye. So depending on the severity of the dry eye, will vary from a simple red eye to an eye that becomes actually very uncomfortable and difficult to keep open. Next slide, please. When you talk about episcleritis and scleritis, next slide, please. So here you're dealing with inflammation, which is then affecting the tissues, the vessels of the coats of the eye. And if they're more superficial, we call episcleritis, and it's usually not a very painful experience. It's a dull ache. It is usually self-limited. It tends not to produce any significant damage to the eye, and it will respond well to treatment. The scleritis, which is the deeper form of inflammation of the coat of the eye, is usually a very different scenario. It's a very painful eye, wake you up at night. The pain can radiate to your joint, to your jaw, to your ear. Is a very difficult pain to control with just simple painkillers. So that's a very different picture, episcleritis from scleritis. Next slide, please. So I'm showing you here an episcleritis. So superficial vessels are inflamed. When we look at your eye, we can tell if they're superficial or deep because you're looking with our slit lamp. Sometimes we can externally look in normal light, we can see that as well. But just to show an example. Next slide, please. And the episcleritis can be a bit of a nodular, so it's a little bit of a lump. So that we call nodular episcleritis. It's still superficial. Next slide, please. Scleritis can behave in a diffuse way. So the eye as a whole is red, or a sector of the eye is red, or it can also present as a nodule, or it can present as a more damaging to the tissue. So we call necrotizing because the tissue is actually suffering loss of its substance. And it can affect the front of the sclera, or as you saw in Chris's anatomical example, a lot of the white of the eye is hidden in the socket. And that's what we call posterior scleritis, when that part becomes inflamed. So the pain, as I said, it can be very severe. Next slide, please. So this is a scleritis, a bit more intense, and sometimes it can involve the cornea as well, which will please describe to you as a keratitis. So the scleritis is this very red eye, usually with significant pain, which makes you come to the emergency room very quickly. Next slide, please. Again, you can see nodules. And the nodules are what you see in your screen. The top one, a bit of a reddish area, and on the lower one, a bit of a whitish area. But these are nodules which can occur in isolation, or can be more than one, but usually just one, and it can recur usually on the same place. Next slide, please. I didn't put in necrotizing. These were the ones that we avoided because they were typical of Halloween images, and we decided not to put them in there. But these are going to be more severe damage to the coats of the eye, and it changes a lot the presentation. JIA, I'm going to mention this very, very briefly here, because it's something that we see as a disease of young people as a primary diagnosis before the age of 16, and you have this common factors which increase the likelihood of developing it: antinuclear antibody, being females, oligoarthritis, and it may very well be. Many times it appears already when you have the disease, but in some patients it may be the first manifestation of the disease. But most of the times it's concurrent or appearing someone who already knows to have the disease. That's why we screen those patients when they have arthritis to make sure we're not missing inflammation in the eye, the uveitis. So here uveitis is a real problem, different from rheumatoid arthritis. Next slide, please. I just want to mention here some manifestations of this inflammation in the eye, because it can produce different things. So you can see in your slide here, the pupil looks distorted because the pupil can get stuck to the lens behind it. That's called synechiae. And when it's affecting the back, as it showed, the lens is a posterior synechiae. The cornea can develop changes, as you see on the bottom left, which is this white stuff, is calcium depositing on the cornea, and that's called band keratopathy. This is a manifestation, usually a very advanced disease. On the bottom right, you see the lens just behind the pupil is looking a bit pale, a bit white. That's a cataract. That's what cataracts look like, and that's how they affect your vision. Next slide, please. So these are examples here of the synechia, the distorted pupil, because it's stuck due to the inflammation. And on the right, a more severe form of synechia, very small pupil, because it's all fibrosis there because of very chronic and this intense inflammation. Next slide, please. This is again the cataract. You can see the pupil looks white, and not only white, you can see the pupil is also stuck down, and that's part of the problem with the inflammation. On the right is the calcium deposit that I showed you in the other slide. This is the band keratopathy that can also affect the vision quite markedly. Next slide, please. In adult life, the patients we see tend, well, of course, you can have the disease starting in early life and then prolong into adult life. And because now we're treating our patients a lot more effectively and picking up the disease very early, the likelihood of severe disease going into adult life is less. But we see a lot of patients who are coming from diagnosis in many years ago, had disease which is very aggressive, started very early in life, wasn't very well controlled. Our treatments are much better now, as Ram will point out later on. We are much better in controlling disease than we were. So the complications of JIA in the eye are less severe now than they used to be. But you heard already about cataract, glaucoma, which is high pressure in the eye, and corneal complications, which were much more frequent before, and we see less of them today. Next slide, please. So I'll just mention very briefly a different group of diseases, just because the uveitis is more of an issue here on the seronegative arthropathies, and ankylosing spondylitis, reactive arthritis. They are the typical examples of this kind of manifestation of uveitis in the eye. Next slide, please. So in these conditions, uveitis is more important. You can have scleritis, you can have vasculitis, which is inflammation of the blood vessels, usually in the back of the eye. Next slide, please. So uveitis will be the front of the eye, that chamber in front of the eye, just behind your cornea, will show the presence of inflammatory cells and protein that may be leaking from the inflamed vessels. And depending on the severity of that, the number of cells will be so large that produces this deposit, this white deposit you see on the bottom right slide, which is called hypopyon. This is just a huge amount of cells, so many that they deposit and go to the bottom, and you can see that as a manifestation of very intense inflammation. So the degree of inflammation will determine what we see when we examine your eyes. Next slide, please. So this is an example here. This patient, you can see there, you look at the eye, both eyes, the little white line at the bottom. That means this is accumulation of cells. It means a very intense manifestation of inflammation in the eye. Next slide, please. Just one thing to mention before I finish is that we treat our patients to control inflammation, prevent damage to the eye. But the drugs we use to treat the patients can also produce reactions. Not only, you can see here a large number, a list of other possible adverse events associated with the drugs. But the eye itself can suffer inflammation or infections, or sometimes consequence of cancers they develop as a consequence of the treatments that we give. So it's just something that we are alert to the patients who are receiving a new medication. If you experience an eye event, in pain, redness, blurring of vision, keep in mind that potential reaction is related to the treatment that you're receiving. And that's something that we need to assess and decide if your treatment needs to be modified and how we're going to deal with that problem. So I'm not going to go into management here. I think Ryan, we're going to talk a lot about that, and we can discuss further in the questions. So thank you. I think that's my last slide. Thank you.
Thank you, Carlos. That was, yes, quite very interesting, but a little scary, I suspect, for quite a few people. So Ram, before we get to the questions and so on, let's come to you. I imagine that dealing with young children who have uveitis must be extraordinarily difficult because, of course, when they're little, they can't tell you what they're experiencing. So it would be really interesting to hear your perspective now on handling and treating children with JIA.
Thank you very much, Elsa. I hope you can see my screen. I think Chris and Carlos have beautifully set up telling you all about inflammation in the eye in the context of rheumatoid arthritis. also in a few other inflammatory arthritis, as Carlos pointed out. And I think the crux is always about this communication between the ophthalmology and rheumatology colleagues, which we alluded to in the earlier presentations, but that's going to be crucial. And of course, as Elsa points out, for the last 2 decades, I've been working exclusively in uveitis in children and how to come up with better therapies, both for uveitis and inflammatory eye disease in children, as well as in adults. So you can hear me, can't you?
We can hear you, Ram. I'm just asking Jeff to put the slides up, as I think you're obviously having a problem trying to get your slides up at your end.
Is it not showing?
There we go. There we go. It's now showing. Carry on. Yep.
So why is ophthalmic? Can you see the slides still?
Yes, I'm just asking Jeff to forward the slide to the next.
Okay, Jeff, can you show the next one, please? Yeah. So why is ophthalmic assessment important in pediatric patients with JIA? And as Carlos pointed out, about a third of the children with inflammatory arthritis, juvenile arthritis, will have uveitis. Most, as pointed out, concurrent to the arthritis, but occasionally the uveitis might be the first presenting feature. But the most important aspect which differentiates the uveitis you see with children from that any eye problem in adults is it's completely silent, so it's asymptomatic. And in the ophthalmology language, they call it a white eye. So essentially, these children, if you don't screen, will have no symptoms until they get perilously close to having significant complications and probably permanent visual damage. And I will show again, but we are still, even in 2024, in a significant proportion, almost a third of the children, when they first present to us with screening, already have a complication. And these complications have been shown to you by Carlos. They can either be a band keratopathy, which is a calcific deposit, in some of them even a small cataract, or occasionally the changes in the iris, which is stuck. But if we can screen appropriately, which we are trying to do, we can prevent most of these complications. Another major aspect of uveitis in children is if for some reason vision's interfered or a child can't see through an eye, then the visual pathways will not develop. So you can become permanently blind. We call this amblyopia. So all the more reason to pick up visual problems in children and treat them. And that's why you may see in children who have squint, you always patch the good eye so that the lazy eye is no longer lazy, because if it remains lazy, the connections to the brain won't develop, and any amount of intervention is too late. Next slide, please. So what are the recommendations? There's a host of recommendations, but the key is any child, as soon as they have a diagnosis of JIA in UK, the UK standards currently, which is actually in a national dashboard, and all the big centers are measured against it, is they should be seen within 6 weeks of the diagnosis of JIA. But if they have symptoms, and every pediatric rheumatologist and pediatrician with an interest will ask for these symptoms, which are unusual, but if they say they are photophobic, or they can't see bright lights, or they have some visual disturbance, then they should be seen within a week of referral. And most large units adhere to this. And as I said, NHS England monitors all the big units on this particular metric. Next slide, please. One of the things that we work closely with ophthalmology colleagues, and Carlos is well aware of this, is in children, more than in adults, the topical steroid drops, which is the mainstay of treatment to start with, themselves can cause cataract. Now, this is difficult, but we are working closely to ensure that the way we treat uveitis in children is to reduce the amount of steroid drops we use and use drugs which we know work well, such as methotrexate and increasingly adalimumab, which is the monoclonal anti-TNF, with which we have a lot of experience in adults and children with arthritis, and now we know works very well in uveitis, and other drugs. But the core message, and I'm showing this slide, which colleagues in America have shown, that just drops on their own can cause cataract. Of course, uncontrolled uveitis can also cause cataract. And more importantly, we want to avoid use of oral steroids in children because it also has impact on growth and development. So really, the way to manage uveitis in children once diagnosed is with the use of disease-modifying anti-rheumatic drugs like methotrexate and anti-TNF. Next slide, please. We did this a while ago, and we find that actually the impact of uveitis in the children has always been underestimated. It has significant issues with schooling. It has social factors such as being excluded. And here are some messages, about how they miss out on lessons. They're worried that they'll go blind. Sometimes they don't understand why so much medication is being given for a condition from which they have no symptoms. And of course, drops are what our children find the most difficult, more than any other medication. Next slide, please. So we have, for the last 20 years, been running a combined clinic, and of course it's a specialist center where both the ophthalmologist and the rheumatologist are in the same room. So this is the way the patient journey goes. They get their visual acuity, they get their height, weight, they get their OCT scans, which has already been explained to you. Nowadays, high street opticians also do these OCT scans. And then the rheumatologist assesses the joints, and usually a rheumatology specialist nurse takes them through all the aspects of treatment. And then there's a combined evaluation. And this is crucial in working together and deciding what is the right drug for that child who has probably joint disease and eye disease, and how severe is the eye disease. Next slide, please. And I think with working together, we've understood how we can share our knowledge, how we can bring expertise with the drugs that have been shown to work in arthritis. And our ophthalmology colleagues are really leading the way in enabling the accurate measurement of disease, which, for example, in arthritis, we are light years away. And the new scans that they have can really measure disease activity very well. Next slide, please. So this is just showing what we do in Bristol. We now have pediatric rheumatology and pediatric uveitis nurse specialists, and our parents and patients really have incredible benefit from them, and they always feedback. And of course, this communication enables us to treat the children with severe uveitis to avoid visual damage. Next slide, please. And really, Jeff, if you just press what we are trying to do, the next one as well, and what we're trying to do in most autoimmune diseases, be that rheumatoid arthritis, ankylosing spondylitis, JIA, is really diagnose disease at an early stage. Juvenile arthritis associated uveitis is probably the best example where with screening, you can pick up early disease and you can avoid damage. Of course, more than joint damage, I think ocular damage gives significant impact on the patients, be they a child or an adult. And this is what we seek to do: identify that window of opportunity, pick up early disease, and avoid disease-related damage. And now increasingly, we think there is a window of opportunity in all immune-mediated diseases, be they joint disease or gut disease or skin disease, where if you treat early, you can switch the disease off. Next slide, please. And I just want to leave you with the fact that a significant proportion, so here I'm showing a large cohort from our center, and you can see that more than 2/3 of the patients will need methotrexate, and about 1 in 3 will need a biologic, and about 1 in 10 will need 2 biologics for control of their uveitis. So in spite of screening, in spite of combined clinics, and in spite of being seen frequently, pediatric uveitis has significant damage if not managed well. Next slide, please. And even in a center where we are very used to seeing this managing early, children with JIA-associated uveitis have a high risk of developing raised intraocular pressure and glaucoma. And children who don't have arthritis, who present with uveitis first, may have a sight-threatening complication called macular edema, which if you don't treat immediately, you will risk losing vision. And cataract, even in 2024, is sadly a frequent complication. So we need to get better drugs, treat them better, and switch the inflammation off early. Next slide, please. But there is good news. We now have a host of drugs which are evidence-based. NHS England approves us to use adalimumab, and with biosimilar adalimumab, access to these drugs have become much more easier. We've also shown that tocilizumab in those patients who are refractory to adalimumab or intolerant to adalimumab, blocking interleukin-6 is helpful. And there is growing evidence that for some patients who are refractory to adalimumab, the Janus kinase or JAK inhibitors may have a role as well. With this, I think that's my last slide. Next slide, Jeff. That must be questions. So I'll, along with my colleagues, take the questions that Ailsa might pose to all of us. Thank you.
Thank you very much, Ram. That was fascinating. All of you, thank you for your presentations. Very thought-provoking. And I remember, Ram, when we came down many years ago to film in your hospital and talk to the children with JIA. I think at that stage I didn't have uveitis, and which I developed a number of years ago. So I've had that for a good number of years, and that little bubble that said, I'm afraid I'm going to go blind. I had a period of time when I thought I was going to lose my sight, and it's a very scary feeling. And I've certainly lost most of the sight in my right eye. And Carlos now looks after both my eyes, but the other one particularly on a regular basis. So it's so important to get that treatment at the right time, because I'm pretty sure if I'd had the right treatment at the right time before I was referred to Carlos, I wouldn't have lost the sight in my right eye. So it's some very, very important messages here tonight. So let's get to the questions. Now, inevitably, because dry eye is such a common symptom in rheumatoid arthritis and JIA, we've had quite a lot of questions about dry eyes. So let's bunch them together and deal with that. So what is the best way to treat dry eyes? There are a lot of different medications and drops and things, but do you have any favorites? Do you have any that you know work particularly well? I'm opening that up to all of you, really. Chris, do you want to start? You must people.
Yeah, well, and it's often not just a specific brand, and the brands change over time, but it's approaches and different sorts of drops. So there's the general looking after your eyes, keeping them clean. Sometimes people, particularly as they get older, will get other problems around the eyelashes, something called blepharitis, applying heat packs that can help with moisture. So there are other things you can do that are more simple. Wearing glasses, and particularly wraparound sports glasses, can increase the humidity around the eyes as well. And those are simple. I mean, Carlos will have better tips than I've got about these things. And then in terms of the drops, I would think about, there are drops that are a bit runnier, things that are based on hypermelose type drops, preservative free. Then there are drops that have hyaluronic acid in them. They're a bit stickier and gloopier. And then that's for the day. And then nighttime use, we sometimes use more ointment-like things that can be applied, which are a bit sticky for the day. So that's a whole spectrum of different approaches. And because the brand will change, I'll often say, I want preservative-free, this sort of eye drop, and then the pharmacist will help me out with whatever's available at the moment. I don't know, Carlos, do you have any other comments about that?
No, I think you're right. The brands is very much the concentration of this formulation in terms of viscosity. It allows the drop to stay in contact with the surface of the eye for a longer time. So when you buy a drop, you see a version, then you see another version, which is a plus or a forte of the same thing, which means it's a forte, it's a stronger version in terms of duration of the contact to the eye. It's a bit more gluey. Some patients don't like it very much, but it does protect the surface for a longer period of time. I think it is, we escalate, keeping in mind that the dry eye is not only a question of the surface not getting wet, but why is it not getting wet? Because you're not making enough tears, and the quality of your tears may be abnormal. And there is many times an inflammatory component to that. So you can try to treat the inflammation as well. Sometimes the use of local steroids for a short period of time. And there's also a cyclosporine in topical formula available in the name of Icurvis, which people can use as well as an attempt to cut down the inflammation, which is itself causing damage to the lacrimals, the glands that are producing the tears. So it's a combination of moisturizing the surface to keep it wet and not suffer the consequences of desiccation, which then lead to the symptoms you have. And the drops and the ointment at night can be helpful in controlling inflammation as much as you can. I tell some patients, it's sad, using glasses, yes, it's an option. For people who already wear them, it's easy. Keep the environment where you're working humidified. Sometimes it's a good idea to keep the air more humid as well, because it helps with the moisture. You feel better after a shower because you have all the steam from the water wetting your eyes. So many times people feel after the shower, my eyes feel better, because you had all that. So there are many strategies you can use. Depends on what you see, the severity of what you see, then you become more aggressive in what you do. But it's sometimes a combination of all the things that are going to work well.
And the only thing I'll add on that is actually in children, what we find is they don't complain much of the dryness because they don't know how to describe that feeling. And so often the patients who have poorly controlled arthritis and a bit of dryness, you find they have secondary Sjögren's, which gets diagnosed late. So they don't know how to articulate a dry mouth or a dry eye. Of course, as an adult, you're much better. So we have to be watchful, and sometimes we pick it up through soft symptoms. So in children, at least, you need to be more vigilant for them describing dry eye.
And I think one of the key messages that comes out of that, Elsa, as well, is that some people I see are using over-the-counter drops for a long time, again and again and again, and it's not working. But if it's resistant, getting someone who really knows, an ophthalmologist, to have a look and to see the inflammatory bit, which will respond to things like steroids and the cyclosporine drops rather than the over-the-counter. So there are lots of people that are suffering for a long time when it could be improved. So I think that was a key message that came out of that. Yeah.
Thank you. Just while we're on that, I've got live questions coming in here on screen. A live question from Emily. Can dry eye cause intermittent sight loss, or is there any other cause for this? Well, it could be presumably lots of causes, but does dry eye of itself cause sight loss?
Well, if your surface is compromised, sorry, Chris, I just came in here, but if your surface of your cornea is affected by the dryness, then of course the quality of your vision can drop. So remember, your cornea is the most important refractive element of your eye. If that is compromised, the surface is irregular because it's too dry, then your vision will become blurred. You will be a poor quality of vision. So it's not an acute visual loss, but it's something that happens depending on what. Sometimes you have an epithelial problem that is more severe. Your vision can drop quite significantly to just reading the big letters on the chart. So it can be affected. So yes, depending on how severe the dryness is, and how your cornea can get involved, your vision can be affected by the dryness.
Thank you. So another live question. It's from a lady called Inga. It's great to hear such a close interdisciplinary cooperation, and I'm very grateful for this very insightful presentation. If I am an adult and have some eye issues, what process should I follow to have my eyes checked specifically for RA-related conditions, please? So, Chris, this is somebody with RA, so presumably their first port of call is likely to be through the nurse helpline or something like that.
Yeah, I guess it could be. So it could be general practitioner, couldn't it? It could be ringing the specialist nurse advice line or bringing it up in the clinics. And we can have a look. You know, I would usually have directed someone to see their optician as well. And opticians now can do some good examinations. They might do an OCT test. But if it's a concern, if I'm worried that there's inflammatory disease, particularly, or resistant problems that I can't very easily treat, that's when I'm going to refer to Carlos and say, I think an ophthalmologist needs to look. And I'm going to be also guided a bit depending on how bad someone's disease is. So someone with very aggressive rheumatoid and high antibodies, rheumatoid factor and anti-CCP, these rheumatoid arthritis tests, those people are the people most likely to get more severe complications. And those people I'm going to be a bit more nervous and want to send to an ophthalmologist sooner.
Okay, thank you. Carlos, one for you here, I think. Can RA affect the optic nerve? if so, what are the symptoms?
Yeah, you can imagine that the white coat of the eye, the sclera we're talking about, as I said to you, a lot of it's inside the socket. And if you have inflammation of the back of the eye, this is where your nerve is located. So the inflammation is happening around the area where the nerve is. You can get an optic neuritis. You can get inflammation of the optic nerve, not a primary nerve problem, but secondary to the inflammation of the white coat of the eye, which is adjacent to that. And that will, when you have inflammation of the optic nerve, one of the very quick things to know, your vision will be severely affected. So vision tends to drop quite sharply. Your color vision goes down. So it's something that is not something that you're going to miss. You will notice that very, very quickly. So it's uncommon, and we say to people, if you have a posterior scleral inflammation, it is important. It is something that has to be treated aggressively, because the risk of visual loss is not small in terms of nerve or macular involvement, because of the proximity to those structures related to where they are located and where the inflammation is.
Okay, thank you. Ram, one for you, I think that came in from Maddie, our services lady who looks after our young people this afternoon. Some parents had a child in remission for 2 years. The child was 4 or 5. Had a follow-up meeting with their pediatric consultant and discovered uveitis. And the child was advised to go back onto methotrexate, and they wanted to add in adalimumab. And the parents were concerned about adding in a biologic drug. I think they may not have appreciated the systemic control that would bring. So do you want to just talk a little bit to that?
Sure. There's two things to mention there. One is many of the parents, and particularly the children, go for a screening visit. The ophthalmologist notices significant inflammation, but the child has no symptoms. So when you say, or when Carlos and I say, you need to start methotrexate, and maybe if they have a small band keratopathy, or if they have a posterior synechiae, we may say it's right to start adalimumab as well. And that might come as a shock to the family, because here's a child who's had no symptoms as far as the eyes are concerned. The problems have always been with joints. And maybe the joint disease has been managed even without methotrexate. And suddenly the doctors are jumping all over them saying, you need methotrexate, you need adalimumab. But the reassuring thing is we now have almost 15 years of data showing that adalimumab, and Carlos will testify to this as well, has really decreased the rates of visual loss and serious visual complications. So some of the pictures that Carlos showed you, and most of us would have seen in the 90s and early 2000s, fortunately, we don't see now. And that's all down to methotrexate and adalimumab. So to all the parents who are listening, if your physicians, rheumatologist or ophthalmologist are saying you need to go, and you're worried, why is it when I have no symptoms? It's to prevent the damage. It's too late once you've had the damage, and damage is usually irreversible.
Thank you. Another one for you, Carlos. Somebody's saying, should I pause taking hydroxychloroquine prior to cataract surgery and restart after healing? Are there any complications related to RA to consider?
No, you don't have to interrupt your treatment because of cataract surgery. It's just carry on as normal. The toxicity of hydroxychloroquine is something that takes years to build. It's not something that happens quickly. Some patients may take 7-8 years of treatment before they get any manifestation of the disease in the back of their eye. And some people never get it. But it's important that you're aware that if your vision gets blurred, you start noticing changes, you should be immediately seen. And we do recommend that patients with hydroxychloroquine are regularly assessed. There is images today that we take with OCT machines. The scans we take from the back of the eye are very good at picking up early changes related to toxicity. So we can, at that point, stop the treatment and then hopefully protect it from progression. I say hopefully because sometimes there can be progression even after you stop the medication. But if you stop early enough, you probably will be able to prevent. So the cataract operation, there's no reason to worry about that. What we tend to say to people, we don't do it anymore, but before we said if you're using an immunosuppressant, stop it before a cataract surgery, but you don't need to do that anymore either. I think for eye surgery, there's no reason to do that. For bigger surgeries, sometimes you're advised to stop medication because of the risk of infection. But for eye surgery, we don't tend to advise it anymore. I think you just have to carry on your medication as normal.
Okay, great. One for all of you here, I think. What impact, if any, does diet have on dry eyes? I have seen suggestions on some forums and some forums that avoiding milk and bananas can help improve dry eyes. Well, I've not heard that one before, but
Well, let me start on that. So, these are really common things for people to ask, and often people will notice when they have their own diet that there'll be a difference. So patients will often say, if I eat this food, my symptoms are worse, and I always listen. But this is in an area of, it would be very difficult to give absolutely certain advice. And my general approach to this would be, if you find something that you can avoid and you're better when you avoid it, avoid it. So some people I look after with rheumatoid arthritis, they feel better when they don't take dairy products. They feel better when they don't take gluten. And if you're just making small adjustments and you're compensating with other foodstuffs, I think that's okay. So if someone finds that, general advice would be the sort of idea of the Mediterranean type diet, the omega-3, some oily fish, or take some fish oils, or take omega-3, plenty of fruit and vegetables, all the things that we think are good for general health, because if your general health is good, that's going to protect all of you, including your eyes. And there's a bit of evidence that rheumatoid is less aggressive when omega-3s, which are the oils that are in fish, particularly, and some plants, that can reduce inflammation a bit. So you'll read lots of stuff on the internet, but I think there are some basic things we can say like that.
I'd agree completely with Chris. If you are having a balanced diet and excluding one or two items wouldn't affect the overall nutritional state, it's fine. The more difficult question, Ailsa, that increasingly crops up is the role of the microbiome. And certainly in an academic setting, we now recognize, at least in mouse models, that what we call as dysbiosis, having an altered gut flora, will lead to immune-mediated inflammatory diseases, which includes uveitis. But the unfortunate truth is none of us know how to modulate the microbiome yet. We understand it's crucial in disease development, but I don't think it's as easy as you might read up things on the internet that you can fix it that easily. So we understand it plays a big role in immune-mediated diseases, including uveitis, but learning how to modulate it is proving much harder.
Yeah. Well, at least we know there's a lot of research going on in this area now, isn't there, which is fantastic, because diet is something that I think people feel, well, at least that's something I can control myself. Yes, Carlos, you wanted to come in.
No, I was just going to say that one of the things you hear about when you're not rheumatoid disease, but if you have a seronegative arthropathy, one of the things we test for is this HLA-B27, which is a marker very closely associated with developing uveitis in the eye. And the link of the B27 with inflammation is very likely to be connected to this biome. So it seems to be that some organisms are more likely in reacting to that, produce an ocular inflammation. So I agree with Ram. We kind of thinking more and more that if we could modify somehow, but we don't know exactly how to modify it, in which way you're going to modify it. And the one thing is very clear. People ask, are these probiotics helpful? Probably not. They're probably nice to drink and you feel good about them, but it doesn't really mean they're changing anything. And it's a good, people are selling a lot of them, but it doesn't really mean it's doing anything.
Okay.
And that's absolutely true. I don't think we know enough to know that any of the commercially available probiotics is immediately going to change the dysbiosis. So I think that's the technical term people use, dysbiosis, leading to all sorts of immune-mediated inflammatory diseases, including inflammatory bowel disease and HLA-B27 related arthritis. And it's probably something that will happen in the next one or two decades of learning how to modulate the microbiome.
So I've got a couple of questions actually here about wet-related macular degeneration. This lady is saying, I eat healthily, but my nan had this. How can I protect my eyes from dratted RA? So is there I mean, anybody can get age-related macular degeneration, but is there any link or association with RA? Is it more easy to get it if you've got RA? Carlos, maybe you want to come in on this first.
No, I don't think there is a clear connection there. I think the issue is that age-related macular degeneration is a disease of aging of time. So, and many times manifestations of RA may get worse over time as well. So I think there's no direct link that because you suffer from rheumatoid, you're going to have more likely to get macular degeneration. No. The issue of macular degeneration, back to the question of diet, there are many formulas out there that have been created to reduce oxidants and try to reduce the damage to the retina by having these formulas, the NRAS formula and others that exist. And there's no real proof that they actually modify the disease in terms of progression. The evidence was very based in trials that demonstrated in an advanced disease it might slow down second eye involvement. But there's no real evidence that it really turns things around or stops the disease progressing. But as far as I know, I don't see a direct link between rheumatoid arthritis and AMD. They are separate conditions. They can just happen in the same individual, coincidentally, because you're aging and you may get manifestations of that disease when you already have rheumatoid on board.
Well, I've got one eye on the clock, and I can see we're getting rapidly towards 8 o'clock. So I'm going to stop the questions there, although we did have a few more, but I think we've answered most of them. So thank you very much for those answers. I think if we can sort of just summarize very briefly, it sounds to me from what you've all said tonight that by keeping good systemic control of the disease, that is going to be, and keeping your general health as well as you can as an individual, eating healthily, exercising, all the things that we know about, that's going to be one of the ways in which we can perhaps reduce getting complications of the eye. Would you agree with that?
Yes.
Yeah, completely. I think that's one of the really important points. And I think, Ram, you mentioned it, Carlos has mentioned it as well. The changes in rheumatoid treatment over the last 25 years that we treat earlier, we treat a bit more aggressively. It's a bit scary sometimes for people having to go on methotrexate and biologicals, but for people with really aggressive disease, they make a massive difference. Some of the worst pictures that, Carlos would showed us of inflammation in the eye that looked really nice, we just barely see that nowadays. That used to be a really regular occurrence, and that's earlier treatment and having these, biological therapies, methotrexate and related drugs. So that message is really important.
Yeah.
Okay.
I think on top of that, and Ram said something very important before, which I'd like to stress, is the parents do get very scared sometimes when they hear about the need to introduce medications. And they fail to understand exactly because the child is not complaining about anything. And suddenly Ram comes to them and say, you have to use the medication. Listen to that and reemphasize what Ram already said. It's really important to follow that advice because this inflammation, if not well controlled, will have long-term consequences to vision and to good life of the child as an adult later on. And that happens also for adults. Sometimes people are very resistant to accepting that some medications are needed. And we're not suggesting them because we have fun suggesting different drugs. We're suggesting them because the evidence supports the idea that if we can cut the inflammatory activity to the maximum, we are protecting our organs from damage. The cumulative damage of chronic inflammation is what is a real problem long term. So you want to stop that and try to keep your eyes healthy and keep your vision for a long time.
Yeah. Well, thank you, Ram, Chris, Carlos. It's been a fantastic evening. So coming up next month, being November, of course, we've got our NRAS live at the end of November, and it's on men. It always is in November. And I believe that Stuart, our COO, will be talking to one of our volunteers, Christian Lamb, who is a pianist and composer, who I think you may have seen featured in one of our videos during RA Awareness Week in September. So he'll be talking to Christian at the end of November. So tune in for that. And I can also tell you, and apologize in advance for mentioning the C word, but our Christmas shop is now open. And so you can get all your cards and your wrapping paper, your Christmas bags and other things, and support NRAS at the same time. So please get shopping on our site. And I think, there we go, Jeff has put up the URL for you. And we will be putting some helpful hints and tips on how not to get completely whacked over Christmas, how to pace yourself, a word I'm not really sure I understand. But you know, how you don't use up all your spoons in advance of Christmas Day. So keep an eye on the websites for that. And thank you all very much indeed for tuning in this evening. It's been a fascinating discussion. Thank you again, gentlemen. We really appreciate you giving up your evening for us. Thank you and good night.
Thank you.
Bye-bye.